from the American Academy of Pediatrics.
Pediatrics is a field dominated by women.
But that doesn't mean women get equal pay.
I would say, sadly, from my perspective, we have not narrowed that income gap.
We can hypothesize that there is actually, whether we want to believe it or not, a certain element of sexism that still permeates within our profession.
But first, it's a new year with a new edition of First Up.
Overall, I think this is really excellent news for our youngest patients during the winter respiratory season, and I'm very, very excited about this.
These stories and more on Pediatrics on Call, the podcast on children's health for the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a look at the latest research from the January edition of Pediatrics.
Oh, the weather outside's still frightful.
But Dr. Moon remains insightful.
And the podcast is still a ball. Welcome back, Pediatrics on Call.
I think after 3 lines of singing, we must show signs of stopping for our listeners. I hope you enjoyed us serenading you into a January edition of First Up with Dr. Rachel Moon, the Associate Editor of Digital Media for Pediatrics.
Pediatrics might be considered a winter sport, so we have articles to share that are going to be central to your clinical practice this month and beyond. Dr. Moon, anything else you want to sing into the mic as we welcome you back to the show?
I think if we want to keep our listeners, that maybe I will not sing into the mic.
It's too late.
But I loved that. That was wonderful. And yes, and you gave Lewis a run for his money.
He loves that song.
Yeah, he does love that song.
He
Rachel,
loves any song, I think.
Also true.
This is very true. Yeah. We won't have you sing, Rachel, but let's have you talk about some of these articles. So I wanted to start with breastfeeding because I've always been very dedicated to breastfeeding. However, with my 3rd child, I had to use formula to help supplement her growth. That was just last year, so finding formula was relatively easy, in part because I had the resources to buy the brands I wanted. That wasn't the case in 2022 when there were formula shortages. Looking back, how did mothers cope with those shortages, and did more attempt to breastfeed as a result?
That is a very interesting question. And if you recall, there were supply chain problems during the COVID-19 pandemic that decreased the availability of infant formula. And this was exacerbated in February of 2022 when Abbott had to shut down their Michigan facility because there was concern for foodborne illness. More than a third of parents reported difficulty getting formula. So this month we have an article by Dr. Luis Estrel and Tatiana Andreeva from the University of Connecticut. They examined National Vital Statistics System data from birth certificates from 2016 to 2022 to look at changes in the rates of breastfeeding initiation before and during the 2022 infant formula shortage crisis. And in case you all don't know, the birth certificate does have a question about the baby's breastfeeding status at the time of hospital discharge. The authors found, it was very interesting, the authors found that breastfeeding initiation increased from 84% to 87.2% during the formula shortage, and that the increases were highest for parents who self-identified as non-Hispanic Black, those who had public insurance, those who participated in WIC, and those who lived in the smallest counties. So I think that some people might hear this and say, oh, well, we should just limit formula availability and then more people will breastfeed. But we have this great commentary by Drs. Rita Wong, Neha Anand, and Heather Shue from Boston Medical Center, and they caution against making simplistic conclusions. A decision about whether or not to breastfeed may seem to be one individual or one family's decision, but it is really reflective of all the supports that are available to those families on a local, state, and a national level. So can these families access lactation help? Do they have paid paid parental leave? And then can they pump when they return to work? There are so many factors that go into this, and we need to advocate for policy changes that will improve everyone's capacity to provide human milk to their babies and not just cut off formula supply.
Well, speaking of supply side, in our hospital, we are finally able to give nirsevimab to all the babies who qualify. And even better, we've got a lot of moms who are coming in having gotten RSV vaccine and not needing nirsevimab for their babies. And I've been so impressed with how well it's working to prevent hospitalizations. But that said, is it also preventing our outpatient colleagues from seeing these babies in their clinics? Rachel, what do we know?
Well, as somebody who works in the outpatient setting, this is a question that I have had, and I was interested to hear Lewis, when he was here last month, talking about nirsevimab being very effective in preventing RSV hospitalizations. So this month, we have an article by investigators from a network of primary care centers in Spain that looks at the outpatient setting, and they enrolled 160 babies who were born after April 1st, 2023, and then were seen for cold symptoms by their pediatrician between November 2023 and February 2024. They also sent nasopharyngeal or oropharyngeal swabs for RSV testing using polymerase chain reaction or PCR, and then they looked at the vaccination history of each of the babies. So the babies who had gotten nirsevimab were much more likely to have RSV negative PCRs at the time that they had cold symptoms. And they calculated that nirsevimab was 76% effective in preventing RSV lower respiratory tract infections that require a trip to the pediatrician. Additionally, those who received nirsevimab between 1 and 8 months of age, they were equally and maybe even more protected against RSV infection than those who received it right after birth. So these results align with earlier data that show a 75 to 80% protection against hospitalization for RSV infection. So overall, I think this is really excellent news for our youngest patients during the winter respiratory season, and I'm very, very excited about this.
Speaking of viruses, the NICU is a place where we worry a lot about infection, and I often joke with the residents it should be the first 3 things on the differential: infection, infection, infection. So it's no surprise then that when it comes to giving the rotavirus vaccine, NICUs can be overly cautious. I know some of my colleagues were curious if there was a cause for concern about a rotavirus outbreak when the vaccine was given to hospitalized babies. What did they find out when they studied it?
So just going back a little bit, if you remember, rotavirus vaccine is a live virus vaccine. And so there are concerns that if you give a live virus vaccine in a setting where there are other immunocompromised people, there could be shedding of the vaccine strain virus. And this could be a problem for all of those other immunocompromised contacts. So most NICUs, because they are full of babies who are immunocompromised, while they're very, very good at vaccinating patients with inactivated vaccines, most NICUs don't administer the live rotavirus vaccine. But this month we have an article by Morgan Zalat, Dr. Margaret Cortese, and colleagues at CHOP and the CDC that looked at the risk of transmission from rotavirus vaccine when you give it in the NICU. So over the course of 1 year, the authors gave rotavirus vaccine to inpatients in the NICU, usually beginning at 2 months and then following the ACIP guidelines. They used Rotatec, which contains the RV5 strain of rotavirus, and they tested stool samples weekly for all patients in the NICU for the entire year, which I cannot imagine. But any samples that were positive for the vaccine strain of RV5, they then conducted a systematic and a geospatial investigation to look for the source of infection. They gave 226 rotavirus vaccine doses to 162 patients, and they found that there was shedding of virus. So 70% of samples collected in the first week of vaccination had RV5 strain detected in it. However, of all of the unvaccinated patients, only 3 of them had stools that tested positive for RV5, and another 2 had stools that were possibly positive. So these 5 patients were fewer than 1% of the unvaccinated population. And when they did this geospatial analysis, it turned out that 4 of those 5 shared a healthcare team member with somebody who had recently been vaccinated with rotavirus vaccine. None of these 5 patients had clinical symptoms of gastroenteritis. None of them had unexplained fever or unexplained feeding intolerance in the 2-week period surrounding their first stool that was positive for RV5. So this is reassuring, and in an invited commentary, Dr. Thomas Sandora from Boston Children's Hospital, he echoed the author's conclusion that although shedding of the virus does occur, transmission is very rare and has no apparent clinical consequence for these infants. So that raises the question, should we change our policies in our NICUs? And I do want to caution, before you go changing your NICU policy, find out which rotavirus vaccine your institution uses, because this study only used the RV5 vaccine, which is Rotatech. There's also Rotarix, which is RV1 strain. And so if you want to use RV1 or the Rotarix, you'll need to wait for a similar study to be done. But for Rotatech or the RV5, it seems like it would be fine.
Well, that does sound like real practice-changing data right there. And I'm excited, but I think Joanna's probably more excited. All right. Well, Rachel, you have led us through a winter wonderland of pediatric topics today. We know from past years that your family likes to ski. Do you have any plans to hit the slopes this winter?
Well, we do go to Vermont periodically, and our family likes to ski, but I do not like to ski. So I will greet them when they come home with hot chocolate and hot food. So I go to the après-ski part of it while they're skiing. And so I just skip the ski part and just go straight to après-ski.
Oh, I remember that now, Rachel.
I don't speak French, but my understanding is before I ski, après.
Is that true, David? You're pretty athletic, so.
I married into a skiing family, and I'm just lucky I make it down to the base. That's all.
Oh, my goodness.
Okay. Well, if you're willing to go out there, you can go out there with the skiers. I think Joanna wants to join me in the après-ski area, and we will greet you after you have skied and prayed for après-ski.
That sounds great.
We'll have hot cocoa waiting for you, David. Well, Dr. Rachel Moon, thank you so much for joining us today.
Thanks for having me. Talk to you soon.
For these articles and more, join us at aap.org/podcast.
Coming up, we'll look at disappointing findings about the income gap between male and female pediatricians.
David, what do you think about people not divulging their salaries?
I mean, it's always awkward to talk about money, but in pediatrics specifically, it's also complicated, right? Depending on the structure of where you work, private or for a hospital, or how many hours you work, pay can be very different across practices and subspecialties.
I know, but I kind of wish it were something we felt more comfortable discussing, because I think transparency in salaries is probably one of the ways we can fight inequities in pay.
There are definitely other pediatricians who think like you do. 2 of them are joining us on the podcast today, Doctors Bobby Byrne and Gary Freed.
If I'm not mistaken, those 2 doctors co-authored a recent paper in Pediatrics, Difference in Pediatricians' Income by Sex Over Time.
You are correct. Dr. Byrne is joining us from Indiana, where she's a professor of clinical pediatrics at the Indiana University School of Medicine and vice chair of education in the Department of Pediatrics.
Dr. Freed hails from the University of Michigan, where he is a professor of pediatrics, director of faculty programs, and associate chair for diversity, equity, inclusion, and government relations, among other things. Drs. Byrne and Freed, welcome to the show.
Thank you so much for having us.
Thanks. Yeah.
So, Dr. Byrne, when we look at a profession like pediatrics, how many doctors are women at this point?
You know, we are the profession, the medical profession with the highest percentage of women. So I think that, in our paper, we quote that there are professions in medicine, such as orthopedic surgery, where there's a very low percentage of women. But in pediatrics, we're 67-ish% women in pediatrics, and that number has grown over the last few decades. So we're a very woman-friendly subspecialty.
For this study, you used the Pediatric Life and Career Experience Study, or PLACES, to get data. And we've talked about PLACES on the podcast before, but Dr. Freed, can you remind our listeners what it is?
Sure. It's an amazing resource for the field of pediatrics, where now across 3 different cohorts, there are literally hundreds of pediatricians at different ages who we're able to, on a very regular basis, an annual, twice a year basis, gather information on how their careers are progressing, what types of issues are important to them at different points in their careers, and how their opinions and experiences vary as their careers play out over time. So it gives a unique glimpse into the way in which people experience the field of pediatrics as a pediatrician.
And I think just to add to that, Gary alluded to it, but it's a longitudinal study. So we're not looking at a group of pediatricians at one single time point. These pediatricians, we've been following some of them now for over 13 years. And so we really have a good idea of what's been going on in their lives and careers over that time period, not just one snapshot in time.
That's really helpful to look at, Dr. Byrne. And in terms of that, you have been looking at pediatricians' income by sex in the past. What did you see then?
Right. In 2016, we published on income differences and found that female pediatricians, after we adjusted for a very robust set of variables, were making about 94% of what their male counterparts were making. So we published that back in 2016, and we're excited or interested, I guess, curious to know if that gap has widened or narrowed over the last 10 years or so.
And what did you find? What happened to it?
Well, it depends on your perspective, but I would say sadly, from my perspective, we have not narrowed that income gap. It hasn't widened, which I guess is, if you have a silver lining, perhaps you could say, but in my opinion, we haven't done anything to narrow that gap yet either.
And I think what's really important here is that oftentimes people just compare salaries between different groups of people, including men and women. And sometimes they find huge gaps, but they don't necessarily account for a lot of things that may be legitimate in terms of causing variation in income or salaries. And one of the things that this study did and the previous study was we took an exhaustive look at so many different factors that could account for the differences. And in fact, in the paper, we start off with a relatively large gap between men and women. And then as we apply different corrections or accounting for several different factors, which everything from part-time, full-time, hours worked, not hours worked, that gap narrows appropriately, but inappropriately, as Dr. Byrne pointed out, that gap does not go away and still remains at a significant amount after you account for or control for so many different variables in this process.
That's so important, Gary, right? Because I know that pediatrics is one of the most, I mentioned, it's very female friendly. And we have for a long time been giving women the opportunity to work part-time as an example. And so people may think that this income gap difference is related to the fact that we are very friendly to allowing or amenable to have people pay attention to their families and things outside of their career and work part-time, but that isn't accounting for the whole difference, like you said, Gary. So important.
So if it's not this thing that people would naturally guess about work hours or career trajectory, then why has this gap persisted? We knew about it in the past. I think everybody wanted to close it, and yet we haven't. Dr. Freed, do you have thoughts on this?
Well, I'd like to say that's $1 million question, but very few pediatricians earn $1 million. So, in fact, we can only hypothesize why this still exists. I can't tell you with any great certainty, but we can hypothesize that there is actually, whether we want to believe it or not, a certain element of sexism that still permeates within our profession. And it can also be factors associated with how well, honestly, and how aggressively people negotiate for salary. And we certainly know from studies that have been done in other professions that men oftentimes negotiate more aggressively when it comes to salaries. And we also know that bosses sometimes maintain quite honestly, a sexist view that men need more money because they're primary breadwinners for their families. And they may be either unconsciously or implicitly or subconsciously accounting for that in the way in which they establish salaries, whether that's in primary care or whether that's in subspecialty pediatrics. And then I guess finally, there may be a situation where sometimes women, when we don't know this, may pursue certain types of jobs over jobs that men may want to pursue, whether those may be, and again, we don't know this, but it could be jobs, let's say, in the public sector versus the private sector that may account for some of this. But ultimately, the bottom line is for the same work, we are seeing a sustained difference in income for women pediatricians versus men pediatricians.
Would you mind if I just added to that as well that Gary and I have had lots of conversations over the years, not just about negotiating at work, but about negotiating at home. And women, we published another study from Places that examined women's responsibility in the home. And turns out, female pediatricians versus their male counterparts are doing more of that work at home that kind of societal norms have placed on women over the years. More childcare, more responsibilities for getting the kids where they need to go, more responsibilities of not just cleaning the house, but maybe contracting who could clean the house. So women maybe aren't doing as great a job negotiating at home as well, which might affect their career and salary as well.
I think Dr. Byrne and I talked about, like she said, we've spent a lot of time going over this issue because I think we both care passionately about it, that we need to, in pediatrics, provide pediatricians with the tools not only to negotiate effectively in the professional space and create equity in the professional space, but help people also defy societal norms to create equity in other spaces as well.
There are so many interesting thoughts in this paper, too. And in the discussion section, you mentioned Claudia Goldin, an economist who won the Nobel Prize in 2023, looking at women in the workforce. And she describes medicine as a greedy job. What does she mean by that, Dr. Byrne?
When she says greedy, not that we are greedy people who want to make a lot of money, but greedy as in it takes a lot of time, right? There's a lot of demands placed on people in medicine, and it can get very greedy with your time. So things like taking call or being on for extra hours. So those are the types of greedy jobs that Dr. Golden describes. And so, things like this comes into play a lot when we talk about pediatricians who have children of their own. And so most women pediatricians are partnered with a spouse who works full time. And so once we have a child, then it's got to give somewhere, right? Who's going to pick that kiddo up from childcare, or who's going to stay home the day the kiddo is sick? And so, that's the kind of greedy jobs that we're talking about, not the monetary greed that you might associate with people who are trying to get rich quick or something like that, but really the kind of greed that it takes so much from our personal, emotional, and professional lives.
Well, we appreciate the thought that y'all are giving to our personal and professional lives, and I think you are enriching it through your work. thank you for continuing that work. And do you have any last takeaways for people feeling discouraged that this gap still exists? Dr. Byrne, do you want to start?
I think awareness is so key, right? Our goal is, I'm in academic medicine as an example, and I would love for our department chairs to look at this work and re-examine, where am I in this spectrum of, I'm hiring both men and women, and I want to make sure that I'm fair and equitable. And I know that there's still disparities that exist. So we're hoping that people will see this and continue to contemplate not only how we can make the pay gap more equitable, but also how do we support women in medicine in general who have lots of other responsibilities in their lives.
And on my end, I want to make sure that we don't think of this as just an academic issue, and that a significant number, certainly in primary care, way more, there's a greater majority of primary care physicians that are not in academic centers. And for many subspecialists, there's huge private practice communities. We need to make sure that this, even though many of us are academics and we who do a lot of these studies are academics, that this is something that transcends the academic world, and that we need to be cognizant and have continued emphasis on trying to ensure that this equity issue plays out in the private sector or in the managed care sector or wherever it is, and not just an academic enterprise.
Well, thank you both, Dr. Byrne and Dr. Freed, for your continued advocacy in this area.
Thank you for allowing us to have the message out. We appreciate the opportunity.
Yeah, thank you.
To read the paper, Difference in Pediatricians' Income by Sex Over Time, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, I don't know if we've ever talked about this, but, I am a practicing hospitalist pediatrician, but I came in on the practice track, and I've always had a little bit of an imposter syndrome because I've got colleagues who've done like a 3-year academic fellowship. But as of now, I am officially a board-certified pediatric hospital medicine specialist from the American Board of Pediatrics, and yay, now my imposter syndrome is completely evaporated, and I feel like a real specialist.
Well, congratulations, David.
Thank you.
Can I just can I say just be breathing a sigh of relief, because that December is just a very busy month for me. It's, the holidays, we do both Christmas and Hanukkah, and both of my daughter's birthdays are the last week in December.
Wow. That is so much.
And my baby turned 1. So I don't even know. I think it's just getting through the holidays, David, is my say ah.
I like that one. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll have an in-depth interview with our new AAP president.
We'll sit down with Dr. Sue Cressley for her Pathways to Pediatrics. I'm Dr. David Hill.
And I'm Dr. Joanna Pargavalinki. Thanks for listening.